My name is Christopher Jabbour, and in this video we're doing an endonasal endoscopic resection of orbital solitary fibrous tumor. This is the case of a 42-year-old gentleman with an 8-month history of diplopia and proptosis. He was seen by ophthalmology and was found to have an intraconal orbital mass. The MRI and scans showed that the tumor was intraconal, lateral to the medial rectus, medial to the optic nerve, and not involving the orbital apex, which makes it amenable to endoscopic endonasal resection. We started by performing a left endoscopic sinus surgery. The front sinus, here shown in green, the ethmoid sinus, sphenoid, and maxillary sinuses were all carefully dissected. We then proceeded by resecting the middle turbinate, which gave us more room to use our scopes and instruments. The first step of decompressing the orbit was identifying the lamina papyracea. Using the caudo, the medial orbital wall was then resected off the periorbital all the way posterior to the face of the sphenoid sinus. Care was taken not to decompress the orbit at the anterior inferior medial strut, as it would cause a loss of support to the globe and potentially hypoglobus. With external compression of the eye, we could clearly see the motion of the orbital content and tumor. Two separate posterior incisions of the periorbital were done, one superior and the other inferior, and then extended anteriorly using a feather blade or knife. The connective tissue and adhesions between those incisions were then pulled posteriorly with a 45-degree Blakesley. The intraconal dissection of the tumor was carried out first using a ball probe. Branches of the ophthalmic veins were encountered during dissection, and those were later cauterized. Blind dissection was not carried out superiorly, as that would be in the anterior ethmoid artery territory. Any injury to that structure at that point would have been difficult to control. With the release of adhesions medial to the tumor using the Bellucci scissors and microdissectors, the tumor was mobilized inferiorly away from the medial rectus and medially away from the optic nerve. Dissection was carried under tension by taking a suture in the tumor itself and pulling on it with a thread. That would need to be gauged, as too much tension would cause the suture to rip through the lesion. That step enabled us to pull the tumor inferiorly and a better edge at dissecting the superior component, inferior to the medial rectus muscle and away from the anterior ethmoid artery. 0.5 by 0.5 saline pledgets were used, both to keep the field dry and to release the adhesions around the tumor. A microbipolar and Bellucci scissors facilitated our next step, which was to cut off the main vascular supply to the lesion and pulling it more medially into the nasal cavity. That gave us access to the lateral portion of the tumor. The adhesions and lateral attachments were then cauterized and released with scissors, gradually until the lesion was fully medialized and pushed inferiorly away from the orbit. The anterior ethmoid artery, the optic nerve, the inferior and medial recti muscles were all left intact. Once completely detached, the tumor was removed from the nasal cavity using a straight Blakesley. The nasal cavity was re-examined, and the sphenoid sinus was visualized in relation to the orbital fat that was herniating due to the medial wall decompression. Absorbable packing was finally introduced to push the orbital fat laterally. This supports the medial orbital wall and prevents asymmetry. The specimen was finally sent to pathology and came back as solitary fibrous tumor. Postoperative endoscopic examination of the nasal cavity showed complete mucosal regeneration over the medial orbital wall. A CT scan was done 2 months postoperatively and did not have any findings consistent with residual tumor. He was finally seen by ophthalmology, and examination of his orbits did not reveal any asymmetry or enophthalmos. His extraocular muscles were intact and his diplopia had resolved. The key points of this procedure include starting off with a standard endoscopic sinus surgery, followed by a medial orbital wall decompression all the way to the face of the sphenoid sinus, maintaining the anterior inferior medial strut to prevent hypoglobus, and then mobilizing the tumor immediately and dissecting away from the anterior ethmoid artery territory, and finally supporting with absorbable packing, pushing the herniating fat back into the orbit to prevent asymmetry.